so for the D1 flexion pattern, the patient is going to start down here at the bottom. That would be the end of D1 extension. You're going to ask them to flex their fingers, wrist, adduct the thumb, and radially deviate. The elbow can be flexing or extending. Then she's going to draw her arm up and across her face. Here we have scapular protraction, elevation, and upward rotation. The shoulder is in flexion, external rotation, and adduction. Now for the D1 extension, you're going to ask her to open her hand, so wrist and finger extension, ulnarly deviate, rotate into internal rotation and come down. So here we have scapular adduction, depression, and downward rotation with shoulder extension, abduction, and internal rotation. We'll start, we'll start here and have you, I'll just tell you to extend your hand, wrist and hand, come on. Okay, ready?
Yep.
Next, we're going to do the D2 flexion first. So we're starting at the end of D2 extension. You're going to ask the patient to open their hands for wrist and finger extension, to ulnarly deviate and extend the wrist. Turn the thumb up and come up and out. So here we have scapular depression, protraction. I'm sorry, that's not right. Stop. Okay, first we're going to do deflection and extension, D2 flexion and extension. You'll have the patient open their wrist and hand, extend the wrist, and turn the thumb and come up and out. So here we have scapular elevation, upward rotation, and adduction or retraction. The shoulder is flexing, abducting, and externally rotating for the D2 flexion. Then for the D2 extension, you're going to have them close the wrist and hand, flex the wrist, go into ulnar deviation, and pull across the body and down. The scapula is depressing, downwardly rotating, and abducting or protracting. The shoulder is extending, adducting, and internally rotating. Okay, this is the D1 flexion and extension pattern for the lower extremity. We're going to start with D1 flexion. The ankle is going to be pulled into dorsiflexion and inversion. The hip is externally rotated, and it is going to come up and across the body. So we end up with pelvic protraction, hip flexion, adduction, external rotation, ankle dorsiflexion, and inversion. From here, the toes will point down into plantar flexion, we'll evert, we will internally rotate the hip, and then come back down into extension. The pelvis is retracting, the hip is in extension, abduction, and internal rotation. D2 flexion. This is D2 flexion of the lower extremities. The ankle is going to dorsiflex and evert.
It starts out here, right? Back that way. Back this way.
The hip is going to internally rotate, flex, and abduct. So you're going to kick it. It's got to flex. So you're going to...
I mean, like flex that. Yeah.
This is D2 flexion of the lower extremities.
Take two.
Take two. The ankle is going to dorsiflex and evert. The hip is internally rotating. And we're going to come and do a kick into flexion and abduction with internal rotation. Now from here, the ankle, this is D2 extension. Point the toes and plantar flex and invert the ankle. Externally rotate the hip. and then extend and adduct. Okay, for slow reversals, you're going to move into concentric contractions with no rest. I'm going to put it in a pattern first, into D1 flexion and extension. So I'm going to have the patient grip my hand and come up and across her face, and then I'm going to ask her to extend, turn, and come back down. So here's slow reversals. Turn, squeeze, and come up and across. Open, turn, and come down. Slow reversal holds are turn, squeeze, and come up and across your face. And at the end, you're going to have the patient hold with an isometric contraction at the end. Open hand, turn, and come down. So there's your slow reversal, and then slow reversal hold at the end. Okay. For slow reversal and slow reversal hold in the developmental sequence, you can use it in a sideline position to facilitate rolling. Here we have the involved side of the body facing up, and I'm going to ask her to push back against my hands. Come on back, both your pelvis and your shoulder, and then push forward. Push forward into my hands. Keep going. There's your slow reversal. Push back into my hands. Get your pelvis going there. And push forward. Now if we were going to do slow reversal holds, we'd have her come on back and hold at the end, and then rotate forward and hold. I could also do that with try to get some segmental rolling where the shoulder and pelvis are doing the opposite motion. So from here, I'm going to have her push back with her shoulder and forward with her hip, and then switch, forward shoulder, back with pelvis at the same time. Get this one going.
Well,
There's a repeat.
I'm confused.
Okay, push forward with this one,
But
and back with this.
Okay, got it.
There. Okay. Push back with your shoulder and forward with your pelvis. Push forward with your shoulder and back with your pelvis. And then if I were going to do a slow reversal hold, push back with your shoulder, forward with your pelvis, and hold. Push forward with shoulder, back with pelvis, and hold. You can do repeated contraction in the developmental sequence as well. Let's say that we're working on slow reversal. She's pushing back into my hands, and there becomes a point in the range where she gets weak. I can give her a repeated contraction, push back, push back, push back to try to facilitate that, and then come forward. And if she starts to weaken, I can give her a quick stretch, repeated contraction to come forward. Push into my hands. There we go. Or you could put the repeated contraction into a pattern. Go ahead and lay on your back. And if there's a point in the range where she becomes weakened, let's do a D1 flexion, and you want to facilitate that, you would give her a quick stretch. You could also do it at the end range to say, push down into my hands. Push, 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 and so on. Timing for emphasis. We're going to say that this is an involved lower extremity, perhaps with hemiplegia. This is a strong lower extremity that's uninvolved. And I'm trying to work on knee extension because she has a lag with this leg. So what I'm going to have her do is to push into my hands and hold with the uninvolved leg to try to get overflow muscle contraction into this leg. You can also use this one with repeated contractions. So once I find where her weak point is, I'm going to have her hold against resistance here, and I may do some repeated contractions on this side as well. So Christy, I want you to come up, push up into my hands. You will notice that this side will continue to come up. This is the weak side, which will lag. So I'm going to ask her to hold strongly with her involved side, uninvolved side, hold, and push, push. There's my repeated contractions to try to gain some overflow into the involved lower extremity. But Okay, with agonistic reversals, remember that you're not going to move your hands. It's a concentric contraction followed by an eccentric contraction. So your hands will stay on the same side of the joint. Here we're putting it in a pattern. I'm going to do D1 flexion again. I'm going to have her come up and across her face. And then I'm not going to move my hands here. I'm going to have her maintain pressure, and we're going to come back down. So here's the lowering, the lengthening eccentric phase. If the patient had difficulty initiating the movement, again, I could do a repeated contraction to have her come on up and across. So many of these techniques can be combined. Then she's going to maintain pressure on my hands as we lower and pull back out. Okay, good. Okay, this is using agonistic reversals in a developmental sequence. So I'm going to do bridging and have her come up into my hands, push up into my hands, and then I'm going to keep my hands in the same place. That was the concentric. Now maintain pressure on my hands and let's lower down slowly. And now she's maintaining pressure and we're eccentrically going back into the starting position. This is rhythmic initiation. Really the one time that we talk about this is to initiate forward rolling with someone who is experiencing hypertonicity, such as a Parkinson's patient, and I want to facilitate rolling. So I'm going to ask the patient, I'm going to say relax and let me move you, and I'm going to take her back into, on her back, and then forward into a semi-prone, and I'm just going to say relax and let me move you. And we'll do that for some repetitions until we feel like she can begin to help. And then I'm going to say, can you help me? We're going to roll forward. Now you help me roll back. Help me. We're going to roll forward and help me roll back. As she begins to take that motion over, it becomes slow reversal. So push into my hands and push back into my hands. So as she can do it actively, it turns into slow reversals. The hold, relax, active movement.
Okay.
Do you remember that one?
I don't know.
Okay, so I'm going to put you, this is again, this is used when there is a weak contraction possible. I'm going to try to use it to facilitate rolling. I'm going to place the patient in a shortened position here and have her push into my hands, do an isometric hold. Then I'm going to have her relax, and I'm going to relax, and I'm going to take her back into the lengthened position, then give her a quick stretch and roll into my hands. Roll forward, roll forward. There we go. Relax is a means to gain range. You can do this one in the presence of pain. You can use either the agonist or the antagonist. I'm going to use the agonist. We're going to work on hamstring length. So here I'm noticing some resistance, and the patient may report slight discomfort with this. And I'm going to ask her to push down into my hands and hold, 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 relax. Then as she relaxes, I'm going to draw the leg up and take it into the new range. Then from there, I'm going to ask her again to push down into my hands and hold, relax, and then I'm going to take the leg into its new range. Okay, next I'm going to demonstrate alternating isometrics and rhythmic stabilizations. This is to gain stability through the trunk. So for alternating isometrics, you're going to have your hands on the same side of the joint. So I'm going to ask her to push back into my hands and hold, and then relax. Then I'm going to ask her to push forward into my hands. Hold, hold, and relax. And I would repeat that as many times as the patient could tolerate, and hold. Now, rhythmic stabilizations, you have one hand on the anterior surface of the joint and the posterior on the posterior of the opposite side, and I'm going to say, don't let me turn you. This is a rotational movement, an isometric rotational movement for the patient, and don't let me turn you. So she's pulling back with this side and forward with the other side. Don't let me turn you. Don't let me turn you. Okay. This next one is rhythmic rotation. It's to try to relax abnormal tone. So here we have a flexor synergy of the upper extremity. I want to try to relax it to pull her down into extension. So I'm going to use the long axis of the humerus and just do slow rhythmical rotations to try to relax the tone. As I feel the tone releasing, I'm going to try to elongate the upper extremity as it releases. This could also be used for the lower extremity as well as the trunk.
Oh, Kristen.
Oh, Kristen.